Thank you, Fadila. First of all, I would like to apologize. Sorry for, keeping you waiting. We had a meeting that took longer than we expected, many of my colleagues here and myself, so apologies for that. Good morning, good afternoon, and good evening. Yesterday, a new case of Ebola was reported near the city of Butembo in the Democratic Republic of the Congo. Butembo is the North Kivu province. It is in the North Kivu province, where a previous outbreak was declared over in June last year. The woman who sadly has died was married to an Ebola survivor. Thanks to the enormous capacity built during the latest outbreak, provincial health authorities have significant experience in responding to Ebola and in preventing onward transmission. More than 70 contacts have been identified, and WHO is supporting local and national authorities to trace them and provide care where needed. So far, no other cases have been identified, but it's possible there will be further cases because the woman had contact with many people after she became symptomatic. Vaccines are being sent to the area, and we hope that vaccination will start as soon as possible. WHO has sent a rapid response team to provide support as needed. The Oxford AstraZeneca vaccine is one of several that has been shown to be effective in preventing severe disease, hospitalization, and death from COVID-19. The emergence of new variants of the virus has raised questions about the potential impact of those variants on vaccines. Yesterday, South Africa announced that it was putting a temporary hold on the rollout of the Oxford AstraZeneca vaccine after a study showed it was minimally effective at preventing mild to moderate disease caused by a variant first identified in South Africa. This is clearly concerning news. However, there are some important caveats. Given the limited sample size of the trial and the younger, healthier profile of the participants, it's important to determine whether or not the vaccine remains effective in preventing more severe illness. These results are a reminder that we need to do everything we can to reduce circulation of the virus with proven public health measures. Several countries are succeeding in suppressing transmission, including those where new variants are circulating. We all have a role to play in protecting vaccines. Every time you decide to stay at home, to avoid crowds, to wear a mask or to clean your hands, you're denying the virus the opportunity to spread and the opportunity to change in ways that could make vaccines less effective. It also seems increasingly clear that manufacturers will have to adjust to the evolution of the virus, taking into account the latest variants for future shots, including boosters. We know viruses mutate, and we know we have to be ready to adapt vaccines so they remain effective. This is what happens with flu vaccines, which are updated twice a year to match the dominant strains. WHO has an existing mechanism for tracking and evaluating variants of the virus that causes COVID-19. It's vital that countries continue to report these variants to WHO so we can coordinate global efforts to monitor their impact and advise countries accordingly. We are now expanding that mechanism to provide guidance to manufacturers and countries on changes that may be needed for vaccines. These developments highlight why it's so important to scale up manufacturing and roll out vaccines as quickly as possible and as widely as possible to protect people before they're exposed to new variants. We also need to continue designing and conducting new trials, and we need to keep a close eye on the impact vaccines are having on epidemiology, severe disease, and death, so we can use vaccines to maximum effect. WHO Strategic Advisory Group of Experts on Immunization, or SAGE, has met today to review the Oxford AstraZeneca vaccine and to discuss these new developments. Tomorrow, I will meet with the chair of the SAGE to discuss its recommendations. To say more about the new study in South Africa and its implications, I'm pleased to welcome Professor Salim Abdul Karim, the co-chair of South Africa's Ministerial Advisory Committee on Covid-19. Professor Abdul Karim, thank you for joining us today, and you have the floor.
Thank you very much, Dr. Tedros. It's indeed a pleasure and an honor to be here with you. I'll just briefly share with you the reasons behind the South African decision and how we are viewing the situation. So put very simply, we have been monitoring how the different vaccines are stacking up in terms of their laboratory assays, whether they are tested in a pseudovirion assay or in a live virus plaque assay. To date, 5 of the 8 vaccines that we've been monitoring have had these laboratory assays. What they show is that vaccine-induced antibodies have greater difficulty neutralizing the 501Y V2 variant than they have against pre-existing variants. We saw substantial declines in some vaccines and less so in others. So for example, with Pfizer and the Sinopharm vaccines, we saw minimal reduction in the potency of the antibodies and minimum changes in neutralization activity. However, with other vaccines, such as the AstraZeneca vaccine, we saw very substantial reductions in neutralizing activity. We don't fully understand what those laboratory results mean, so we need clinical data. Fortunately, 3 of the vaccines have been tested in South Africa, where the 501Y V2 variant constitutes about 80 to 90% of the circulating viruses. The first results that we heard were from a vaccine produced by Novavax. And there we heard, quite concerningly, that the efficacy of the vaccine was 89% in the UK, but only 49% in South Africa. That was the first indication that efficacy levels would be diminished in addressing the 501Y V2 variant. Most recently, we saw this week the release of a study. It's quite a small study with 2,026 participants, largely young individuals. And one of the important things is that the trial used a dosing interval that is quite short compared to the newer, longer intervals that are being proposed by AstraZeneca. So looking at that, what was shown that while the overall efficacy of the AstraZeneca vaccine was 66% in the largest study that include the UK, Brazil, and South Africa, the South African data on its own showed only 22% efficacy. It should be noted it has a very wide confidence interval that includes even 60% protection in that confidence interval. But that study, which looked at only mild and moderate infections, raised concerns. Not because that we were not expecting some diminishing activity, but it was the level to which it was diminished. And so now we are unclear and uncertain about the efficacy of the vaccine in preventing hospitalization and severe disease. We know from the overall trial that the AstraZeneca vaccine is effective against other pre-existing variants. We're just not confident about its efficacy against the 501Y V2 variant. And so we've proposed an alternative approach, a new approach to the way in which to roll out the vaccine. And one proposal that's currently being considered is to roll it out initially just in a stepped manner, where the first step includes about 100,000 individuals that are vaccinated, in which we monitor the hospitalization rates. If they are below the threshold that we are looking for, then we're confident that the vaccine is effective, again, in preventing hospitalization, and then we can roll it out. Alternatively, if it's above that threshold, then we'll need to look at alternatives. So put very simply, we don't want to end up with a situation where we've vaccinated 1 million people or 2 million people with a vaccine that may not be effective in preventing hospitalization and severe disease. We think that in order to do so, we have a more prudent way in which we can do that, which is to make an assessment and then roll it out on a grander scheme. So all that has been suggested at this point is to delay the rollout of the AstraZeneca vaccine until we have the processes in place to undertake this kind of stepwise implementation approach. On that note, Dr. Tedros, thank you very much.
Thank you. Thank you so much, Professor Abdul Karim. And we appreciate everything you're doing in South Africa and globally in the fight against COVID-19, as you have done for so many years in the fight against HIV. You have our respect and appreciation, Professor. In the next few days, WHO expects to make a decision on the emergency use listing of the Oxford AstraZeneca vaccine for the 2 sites in India and the Republic of Korea, which will produce it for COVAX. We're committed to using all available data to make these assessments. In the meantime, COVAX continues to prepare for its first quarter distribution and to add to its vaccine portfolio. To discuss the implications of these new developments in South Africa for COVAX, I'm pleased to be joined today by Dr. Seth Berkley, the Chief Executive Officer of Gavi. Seth, welcome once again, and you have the floor.
Thank you, Dr. Tedros, and also thank you, Professor Karim. It's good to have you here with us. You don't have to be an epidemiologist, as Dr. Tedros said, to know that these viruses evolve and mutate over time. I think the events of the past weeks, the emergence of these new variants, and this has been a sequential conversation. We've heard about the B.1.1.7, known as the UK one. We just heard about the South African one. There's also one in Brazil that is known as P1. What this serves to highlight that our scientific response needs to adapt if we're going to successfully beat this pandemic. It isn't simple. It isn't going to be one strain globally. So from the perspective of COVAX, the vaccine pillar of the ACT Accelerator, there are a number of lessons that are important from these events. The first is that manufacturers must be prepared to adjust the adjust to COVID-19 viral evolution, including potentially providing future booster shots and/or adapted vaccines if found to be scientifically necessary. We don't know that now, but that is something that obviously needs to be carefully followed. It's also clear that trials have to be designed and maintained to allow efficacy to be assessed over time and to be of sufficient scale and diversity to enable clear interpretations of the results. We know that we need much better global genomic surveillance, and that has to be backed by rapid sharing of data to allow for the global coordination of response. And then lastly, and I know this has been said, but it needs to be emphasized, priority needs to be given to vaccinating high-risk groups everywhere to ensure maximum global protection against old and new strains and to minimize, as best as the vaccine can, the risk of transmission. Because we know the more that the virus is allowed to spread, the more it is allowed to be transmitted, the more opportunity it has to adapt and mutate. All of this underlines the need for a global multilateral solution based upon the principles of equitable access. It also underlines the need for a diverse portfolio of vaccine candidates suitable for all context, setting, and events. In terms of COVAX, we have signed advanced purchase agreements with AstraZeneca and the Serum Institute of India, and we've published plans to distribute nearly 350 million doses in the first half of the year, hopefully starting later this month, should the emergency use listing be forthcoming that Dr. Tedros just talked about. And of course, this is the first of many vaccines. We'll also be looking at the SAGE guidance that you heard about in terms of their views on the best use of this vaccine in different groups and in different areas. We're continuing to work through our partner, CEPI, and Richard Hatchett, CEPI's CEO, is on this call to optimize and extend the value of these existing vaccines. We're looking to continue to procure new candidates for our portfolio for use later in the year, including ones that would be adapted for the new variants if scientifically indicated. As we have done up until now, we'll continue to keep you updated on all these developments as and when they occur. So thanks for giving me a chance to speak, and back over to you, Dr. Tedros.
Thank you. Thank you so much, Seth. And we look forward to our continued partnership to roll out vaccines. I would also like to welcome Dr. Richard Hatchett, the CEO of CEPI, which is a key partner in COVAX. And Richard is also available to answer questions from journalists. Thank you once again to all our guests, and apologies for the delay. And Fadila, back to you.
Thank you, Dr. Tedros, and to our guests. I will now open the floor to questions.